Hi, everyone. On today's podcast, we're going to talk about the ethics and evidence on circumcision. Welcome to the Evidence-Based Birth Podcast. My name is Rebecca Decker, and I'm a nurse with my PhD and the founder of Evidence-Based Birth. Join me each week as we work together to get evidence-based information into the hands of families and professionals around the world. As a reminder, this information is not medical advice. See evbirth.com/disclaimer for more details. Hi everyone, today is the day that we are releasing information about routine male newborn circumcision. We have been receiving requests to cover this topic for years now, and it wasn't until last year that I made the decision that it was time for us to tackle this important topic. In today's podcast, I'm going to talk about the relevant human anatomy, where circumcision came from, why some parents choose non-religious circumcision today, how common circumcision is around the world, the procedure itself, the evidence on circumcision for preventing infection or disease, including the limitations of that evidence, the potential health risks from circumcision and complications that can occur during and soon after circumcision, and a discussion of the evidence in light of ethics and human rights. As I'm looking at the article right now before we've put it online, so it's in a Word document, it is actually a total of 45 pages long. So needless to say, I won't be able to go into incredible detail about each one of these topics, but I will give you a brief overview of each of these topics, and I encourage you to go to evidencebasedbirth.com/circumcision to get all the details. Before I start with the content, I did want to say that I know that this is an emotionally charged topic for many people. We understand that the topic of routine circumcision is a controversial and complicated one. We've tried to anticipate as many questions as possible to aid your listening to this podcast and reading of the article. Earlier, you can access the full-length article with all the details at evidencebasedbirth.com/circumcision, and you can also find our answers to frequently asked questions about the article at evidencebasedbirth.com/circumcision FAQ. That's all one word /circumcision FAQ. We also understand that your own personal experiences and beliefs will inform how you digest or take in the information in this podcast and the article. And I invite you to consider your emotional response and potential reaction to triggers when you're listening to this podcast. I ask you to be aware of your emotions, and I encourage you to separate your emotional response from the information that I'm going to be giving you in this podcast. If while listening to this podcast or reading the article at evidencebasedbirth.com/circumcision, you feel your heart rate going up, or you feel foggy, angry, intensely emotional, or unable to shake a past memory, it could be that you are experiencing a trigger. A trigger is a sign that you need to turn inward to process these emotions and not outward. Some tips for inward processing include journaling, going outside, meditating, praying, or talking with a trusted friend or counselor or therapist. You can listen to the Evidence-Based Birth Podcast, episode 87, for more information on processing triggers and why circumcision may be a triggering topic. So why did we write this article and publish this podcast? At Evidence-Based Birth, we stand for providing parents and their communities with evidence-based information on routine male newborn circumcision. Parents in the United States are usually offered routine circumcision in the hospital without having complete information on the ethical debate, risks, limitations of the research on proposed benefits, or alternatives. And for many, many years, parents and professionals have been emailing us and asking us to shed light on circumcision. We don't shy away from hard topics, and we feel a great responsibility toward our community who trusts us to provide quality information. I am not here to judge or shame anyone or to say my opinion about what you should do or should not do. What I want to do today is offer information. So let's get started. Are you ready? I'm not sure if I am, but we've been sitting on this information for a long time, and it's time to get it out into the world. Male circumcision is defined as the partial or total surgical removal of the foreskin, also called the prepuce, which is specialized tissue that covers the head or glands of the penis. One of the reasons we're covering this topic is because I'm located in the United States. The US is an unusual country in that the vast majority of newborn circumcisions are done for non-religious reasons. And that's what we're going to be focusing on in this podcast, on the evidence and the ethical debate around non-religious circumcisions, which we're going to call from here on out routine circumcision. However, the overall topic of circumcision is ripe with historic and religious context. So in the article and in this podcast, I will mention the religious context in the history section. Our discussion of any religious history is purely to provide background on this issue as part of discussing the ancient history of circumcision and the eventual development of American cultural or routine circumcision. In the United States, where I'm located, the overall rate of newborn circumcision is on the decline here. However, circumcision is still the most frequent procedure performed on children during hospital stays. It's more than 10 times as common as any other pediatric surgical procedure. And it's the only invasive procedure considered, quote, non-therapeutic or not medically necessary that's regularly performed on healthy infants in our country. Circumcision is so familiar and routine in U.S. culture that many care providers and parents that I talk with scarcely think of it as a surgical procedure at all. Instead, they see it as one of several relatively minor newborn medical procedures performed at the hospital before discharge. However, it's not just a surgical procedure. It's also known as the world's most controversial surgery. I know that opinions on newborn circumcision are diverse and very emotionally charged. There are people who are pro-circumcision. They believe that circumcision should be kept as a parental choice because there may be possible health benefits. On the other hand, there are people who view the prepuce as having sexual value as well as serving various physiologic functions. People on this side argue that circumcision is a traumatic experience for the infant and a violation of the child's right to bodily integrity. Now, you all know that you're listening to the Evidence-Based Birth podcast, so you might be wondering why we chose to talk about the ethics alongside the research evidence on circumcision. Routine male newborn circumcision is an irreversible surgical removal of tissue from the sexual organs of a minor. There are ethical questions about removing or altering any minor's genital tissue, regardless of whether or not there is research examining medical benefits. We're going to get more into depth in bioethics later on in this podcast, but I want to introduce the major principles of bioethics before we get started. There are 4 recognized principles of bioethics. The first is respect for autonomy. This means that a patient has a right to informed consent and refusal for medical procedures. With children who are not able to provide consent, the authority to make medical decisions usually lies with the child's parents, who have a duty of care towards the child. This involves seeking to promote the child's long-term best interests, and this is called proxy consent. Non-maleficence is the second principle of bioethics, and this means do no harm. Care providers should not intentionally cause harm or injury to the patient. Now, sometimes there are situations where harm is unavoidable, but there is a net benefit, meaning there's more benefits than risks for the patient. In these situations, the autonomous patient must weigh the potential benefits and risks and make an informed decision in light of their preferences and values. In the case of children who have medical conditions, parents usually have this authority. Beneficence means do good. This is another bioethics principle. Care providers have a duty to benefit the patient and take steps to prevent harm. Finally, justice. Justice means that healthcare resources should be distributed fairly in society. The principle of justice also refers to everyone having an equal opportunity for health, and healthcare should not be based on sex, race, or religion. So I'm going to talk more about these principles later on in this podcast. First, I want to get started with the prepuce in human anatomy. All human embryos start out with the same sex-neutral genital structure, and then they go on to develop more stereotypically male or female genitals through a process called sexual differentiation. In males, the embryonic cells normally develop into a glans penis, that's the head of the penis, covered by protective tissue called the male prepuce, commonly known as the foreskin, which covers the head of the penis when it is flaccid and not erect. Similarly, females develop a glans clitoris, which is covered by the female prepuce, better known as the clitoral hood. Newborn males are normally born with their prepuce fused to their glans penis by a membrane. This tissue connection is natural and normal at birth. meaning that the prepuce cannot be retracted or pulled back from the glands. If left intact or uncircumcised, the prepuce gradually becomes less attached and more retractable over childhood and adolescence. By 10 years of age, more than half of boys can completely retract their prepuce, and by 17 years of age, more than 99% of boys will be able to retract their prepuce with gentle manipulation. Now, for the rest of this podcast, I've chosen to use the term intact instead of uncircumcised, since referring to a penis as uncircumcised suggests that circumcision is the default or normal state, and that the absence of circumcision is abnormal or alternative. Now, the prepuce is a normal part of the body's genitals. Like I said earlier, it's common to both males and females, human and non-human primates, and actually all mammals. The prepuce is not just skin. It's actually a part of the body called a mucocutaneous junction, or a boundary between typical skin and moist, fluid-secreting skin, or mucosa. In this way, it's similar to the nose, lips, eyelids, and labia minora, the inner folds at the opening of the vagina. The prepuce is nerve-laden tissue that, in males, covers and protects the glans penis and the male urinary opening from irritation, such as from soiled diapers or tight clothing. In newborns, when the prepuce is removed through circumcision, this does expose the head of the penis to urine and bowel movements in the diaper. After healing and during later development, the glans penis that is circumcised is exposed to air and to friction from clothing. As a result, the circumcised penis becomes keratinized, meaning that the skin on the glans penis changes from shiny, smooth, and moist to dry and slightly more toughened or calloused. Now, in an attacked adult male, the average prepuce is about the size of a credit card if you stretched out the skin, but the size can vary considerably between men. Now, when an intact man's penis is flaccid or not erect, the prepuce covers the glans penis so that the head of the penis is at least partially hidden. However, during an erection, the prepuce naturally retracts back along the shaft, exposing the glans, and during an erection, the intact penis looks nearly identical to a circumcised penis, with the exception of a band of pleated tissue that gathers behind the glans. A lot of people have asked us about the care of the intact penis. Care of the intact penis is simple. It can be washed with water during the baby's bath, and non-irritating soapy water may also be used. The main care thing to remember with babies who are intact is that when the prepuce is still attached to the glans, it should never be retracted or pulled back toward the abdomen by force. For example, you would never retract it or pull it back during a bath or during a medical checkup. Forcibly retracting the prepuce can cause pain, tears, and bleeding. There's no need to wash beneath the prepuce until it's more easily retractable later in childhood. The natural buildup of oils and old skin cells beneath the prepuce is called smegma, which is similar to what builds up in females. The smegma, along with occasional erections, helps the prepuce to gradually separate from the glans until it's fully retractable later in childhood or adolescence. Once a male discovers on his own that he can pull his prepuce back, he should be taught to clean the area between the prepuce and the glans with water as part of a regular bathing or showering routine. With the care of a circumcised penis, parents are instructed to replace a lubricated dressing with every diaper change for the first 24 hours after the procedure. Parents are also usually told to clean the baby's wound with warm water and a cotton ball daily. After 24 hours, the lubricant is applied directly to the baby's wound on their penis without gauze during each diaper change for the next 3 weeks, and within a few days after the circumcision, a scab will start to form. Next, I want to talk about where did circumcision come from. Scholars think that circumcision is probably one of humankind's most ancient rituals. We know from Egyptian mummies and wall paintings that circumcision goes back at least as far as ancient Egypt, but it's possible that the practice came about in different cultures for different reasons. There's very little evidence for any of the theories of how circumcision came about in its ancient origins, but here's a partial list. Some scholars think that circumcision is a mark of belonging to a certain social group, such as similar to having a tattoo or body piercing. There are ancient accounts where circumcision is used to punish prisoners of war. For example, there is a story in 1 Samuel in the Bible about this. Circumcision has been used as a tribal rite of passage into manhood, a way for authority figures to demonstrate their power, a test of bravery and pain endurance, a blood sacrifice, a way of accentuating the masculinity of males by removing the female elements of the genitalia, because the foreskin was thought to be similar to the labia in females, in the same way that in some cultures, the masculine element in females, glans clitoris, was removed to accentuate their femininity. Scholars also think it was done to marginalize women by excluding them from an important ritual and thus preventing them from assuming leadership roles within the community. Circumcision is also performed as a religious rite. Observant Jewish parents have carried out the ritual for more than 3,000 years. But actually, most male circumcisions around the world are performed in Muslim communities. Roughly 2/3 of all circumcisions are among Muslims. For Muslims, circumcision is not mentioned in the Quran, but Prophet Muhammad recommended it in his teachings and his sayings, which became the basis for Islamic law and practice. Some Christians also practice circumcision. However, the New Testament specifically states that non-Jewish Christians do not need to be circumcised. To give one example, Galatians 5:6 in the New Testament states, "For in Christ Jesus neither circumcision nor uncircumcision has any value. The only thing that counts is faith expressing itself through love." So among Christians, circumcision is usually done for cultural rather than scriptural reasons. In this podcast and in the signature article available at Evidence-Based Birth, we are focusing mainly on modern, non-religious circumcision. One of the most important resources we've found about the history of circumcision comes from a book called Circumcision, A History of the World's Most Controversial Surgery by David Gallagher. According to David Gallagher, we can trace the origins of routine, non-religious circumcision on healthy newborn males back to the United States in the 1870s. At the time, there was a prominent physician who eventually became president of the American Medical Association. This doctor developed a theory that circumcision could cure many types of paralysis and hip and joint disease by quieting the nervous system. This same doctor and many other doctors also recommended removing the external part of the clitoris in females to treat female, quote, nervousness. After he developed his theories, there were many U.S. and British medical professionals who believed his claims that circumcision could cure all kinds of diseases. Soon after, other physicians began to argue that preventing disease is even better than curing disease, and they insisted that circumcision would benefit any male and society at large. Early physicians claimed all kinds of, quote, benefits from circumcision, that it could prevent bedwetting, sexually transmitted diseases, seizure disorders, impotence, homosexuality, paralysis, masturbation, and more. Also around this time period, around 1890, germ theory caused the general public to have a great fear of germs, and many believed that circumcision was necessary to keep the penis clean and germ-free. Racist beliefs were circulated in which people began to believe that the intact or uncircumcised penis was associated with recent immigrants, Black people, and the poor. And there were even overtly racist proposals to forcibly circumcise Black males. Now, during this time period, midwives, who were the ones attending home births, rarely performed circumcisions. So a circumcised newborn became a status symbol of having given birth with a physician in a hospital. So modern circumcision began in part for perceived hygiene and social class status. However, medical historians argue that one of the main reasons circumcision became mainstream was because of a major public effort to stop masturbation. In the late 1800s and early 1900s, many people were scared of masturbation. They thought it was a cause of mental and physical illness. Now, when an intact male masturbates, they can move the prepuce back and forth over the glands for stimulation. So people thought that removing the prepuce would be a way to prevent masturbation, or at least make it less desirable. So circumcision began to be widely done as a preventive measure, treatment, and punishment for masturbation. In fact, John Harvey Kellogg, the founder of Kellogg's Corn Flakes, was a leader in the anti-masturbation movement. We read some of his early papers, and he says things that, like, children should be watched at all times, day and night, for fear that they might, quote, defile themselves if left alone. To prevent and treat masturbation, he recommended several strategies: bandages, tying the hands, electrical shock therapy, caging the genitals, and especially circumcision as, quote, this remedy is almost always successful in small boys. However, after this whole time period, something interesting happened. This modern non-religious circumcision trend started in the United States and Britain, but circumcision remained widely popular in U.S. culture and fell in popularity among the British. So what happened was that Britain was in a serious economic recession in the 1940s after World War II, and their government-funded National Health Service, the NHS, was established to provide affordable health care. Every single medical procedure in Britain was subjected to careful study because they didn't want to waste precious resources. In 1948, the NHS decided to decline to cover routine circumcision. And shortly after that, circumcision was pretty much abandoned in the United Kingdom and never became embedded in British culture the way it has in US culture. So now that brings us up to today. This is the year 2019. Why do parents choose non-religious circumcision today? Well, most parents that I talk to have no idea that non-religious circumcision became popular in the US in a large part as a way of reducing male masturbation. Instead, parents today who choose non-religious circumcision for their sons do so for a variety of reasons, such as concerns about hygiene and social norms. Also in the US, which is very unique, some parents may choose circumcision because it's a procedure that care providers routinely offer to them. It's seen as the default choice. I found 3 recent studies on why parents choose circumcision. One study in Canada found that the parents that supported circumcision cited hygiene and prevention of infection or cancer, and the father is circumcised as their top 3 reasons for supporting circumcision. The parents in the study that did not support circumcision gave their top 3 reasons being that it's not medically necessary, they had concerns about infection or bleeding, or the father is intact. Interestingly, the data analysis found that the circumcision status of the father was the most important influence on their decision. Another study of parents in Texas also found that the circumcision status of the father was the most highly correlated factor with regard to the infant being circumcised. Another U.S. study in 2015 surveyed 60 parents who chose or planned to choose circumcision. Overall, they found that the parents' responses fell into 2 main categories of beliefs, either health-related and personal cultural, and most parents gave a mixture of beliefs from those categories to support their decision. Now, one of the interesting things about that study, which was carried out by Sardi and Livingston, was that they found that the perceived health benefits were closely tied to cultural beliefs. This means that parents' beliefs about potential health benefits are greatly influenced by their cultural beliefs about the practice. What this means is that if newborn circumcision is perceived as socially normal, then an individual is more likely to exaggerate the significance of health benefits and diminish the risks, or vice versa if they see circumcision as socially abnormal. Because there was so little research on why parents in the US choose circumcision, I ended up doing a Google search for, quote, why I chose circumcision for my son, and I found a lot of mommy blog results. And a lot of them actually talked about a statement from the American Academy of Pediatrics stating that the health benefits outweighed the potential dangers. We're going to talk more about that American Academy of Pediatrics statement in a little bit. But clearly, in addition to social norms and concerns about hygiene, perceptions about research evidence and purported benefits may also factor into parents' decision-making in the United States. And don't worry, we'll go into that research later on. Another reason that parents in the U.S. give doctors for wanting circumcision is that they're worried that their child might be teased or bullied later in life if their penis is not circumcised. In other words, they're worried about locker room teasing. So I was curious if this was evidence-based. We ended up finding only one study on the topic of teasing and bullying about penile appearance. This study came from the University of Iowa, and they interviewed or surveyed 290 undergraduate male students about penile teasing during middle and high school. There were about 251 circumcised men in the study and 39 intact men. And the majority of participants reported being naked often in a locker room. Of all the men in the study, 10% reported that they had been teased about their penis, and 47% reported that they had seen someone else get teased about their penis at some point. Interestingly, penis size was the reason most often identified by those who were personally teased or witnessed teasing. This made up the bulk of the reports of teasing, about 75% to 83%. Aside from size, the participants reported that 24% of the teasing they witnessed in the locker room was about being intact instead of circumcised. When they compared the rates of personally experiencing penile teasing in the intact group versus the circumcised group, they found no difference in the rates of experiencing teasing between the groups. While the study only included a small sample of intact men, only 39 men, the findings are still informative because nearly half of the 290 total participants were able to report on teasing that they witnessed. And they reported that locker room teasing was far more related to penile size and penile appearance. Another statement that we hear from parents in the U.S. is they say things like, "I want my son to look like everyone else." Parents that I talk to are usually surprised to learn that most men around the world are not circumcised. They're also usually surprised to hear that there's been a decline in male newborn circumcision rates in the United States. Now, in some areas of the United States, the majority of boys are intact and circumcised boys are in the minority. The World Health Organization estimated in 2007 that about 30 to 33% of the world's males aged 15 years or older are circumcised. Of these circumcised men, about 69% are Muslim, 1% are Jewish, and 30% are circumcised for non-religious reasons. Of the men circumcised for non-religious reasons, 43% are in the U.S. and 57% are in every other country combined. Another way to look at it is that only about 10% of the world's males are circumcised for non-religious reasons, and more of those men live in the United States than in any other single country. In the U.S., an estimated 71% of adult men are circumcised, but the current rate of routine newborn circumcision is much lower, and research suggests that the rate continues to decline. The CDC published a report in 2013 tracking trends in male newborn circumcision from 1979 to 2010. The overall rate of newborn circumcision before hospital discharge fell from 65% to 58% over the 32-year period. So as of 10 years ago, only about 58% of newborn males in the U.S. were being circumcised in the hospital before discharge. Now, given the downward trend, it's possible that this number has fallen even more since then. However, the CDC has not reported anything since then. There's also an interesting amount of geographic variation in newborn circumcision rates in the U.S. The Midwestern states have the highest regional rate with a high of 83% in 1998 and a low of 69% in 2009. The Western U.S. states have the lowest rate of circumcision in the U.S. with a high of 64% in 1979 and a low of 31% in 2003. This means that as of 2003, 7 out of 10 male babies in the Western U.S. were not circumcised in the hospital after birth. Now, in the circumcision procedure itself, in a typical hospital circumcision procedure, the baby being circumcised is placed on his back in a holding device with arms and legs restrained. The skin around the baby's penis is cleaned, and pain medication is applied around the penis as a cream or injected. There are several different devices that procedures use to circumcise a baby's penis, including the Gomco clamp, the Mogen clamp, and the Plastibell ring device. If you want to learn more about these procedures, we have direct links in the article to videos of real circumcisions published by Stanford Medicine. With all three of these techniques, the baby's prepuce is first pulled out beyond his glans penis, and a surgical tool is used to sweep between the prepuce and glans to tear apart all of the skin adhesions. Remember, newborn males are born with the prepuce fused to the glans, so they have to tear apart these adhesions in order to separate the prepuce from the glans. This is a step that's usually not needed in adult circumcision because they no longer have the prepuce fused to the glans. With the newborn circumcision, after the baby's prepuce has separated from the glans with the tools, the provider uses one of the three techniques that I mentioned earlier. They either cut out the baby's prepuce during the procedure with the Gomco clamp or the Mogen clamp, or they send the baby home with the Plastibell ring device tied tightly around the prepuce to cut off circulation. If the Plastibell ring device is used, the plastic ring and dead prepuce tissue usually fall off within several days to a week. The surgical procedure takes about 15 to 20 minutes from preparation to completion. Afterwards, to stop bleeding, the provider covers the baby's wound in a dressing or gauze and applies pressure. And then the parents are instructed in the wound dressing changes that I talked about earlier. In the article, we do have some pictures or graphics of before and after a complete circumcision so that you can see exactly which tissue is removed. Moving on to the evidence on circumcision to prevent infection or disease. Researchers have carried out many studies looking at the medical effects of male circumcision, despite the fact that there's been growing ethical concerns about these studies. We spent nearly a year looking at the research on this topic, and as Anna Bertoni, my research editor, and I conducted our literature review, it became clear really quickly just from glancing at the research, that most researchers based in the US, where the majority of medical research is done, took the cultural and ethical acceptability of male circumcision for granted. And so when you look at their studies, the explicit goal of most studies was to, quote, verify the perceived benefits of the surgery. Indeed, much of the research from the Western research community from the United States on male newborn circumcision seemed to be biased towards emphasizing benefits while downplaying risks or harms. In fact, in many of the studies, they didn't even look or measure risks or harms. Now, the bias in the studies can be quite personal, even down to the circumcision status of the researcher who's conducting or interpreting the research. On a wider scale, if a research community consists of mainly circumcised men or circumcised parents in the study, they may simply view the practice as normal or expected. Now, this bias can directly influence the results of the study because it affects the variables that they study, how the studies are carried out, and whether or not they even measure potential harms or risks. Now, in regards to the limitations of the research on circumcision, we found pretty quickly that one of the main problems with the research on the proposed benefits of routine male circumcision in healthy newborns is that much of the research comes from contexts in which circumcision was performed on males during adulthood. Now, an adult male circumcision is different from a newborn circumcision. In fact, in many of the studies where they do male adult circumcision, they're providing those men with individualized counseling on safe sex and free access to condoms. This is not something that you do with newborn male circumcision. This led me to wonder, if there's so little research on newborn circumcision, have there even been any randomized trials on it? In our search, we went back to the beginning of the medical research on circumcision and found that routine newborn circumcision became widely promoted by medical professionals without ever being tested first in randomized controlled trials. So there was never any requirement to randomly assign newborns to routine circumcision or no circumcision before recommending the surgical procedure as beneficial. Still today, none of the proposed benefits are supported by data from a randomized controlled trial of healthy newborns assigned to routine circumcision or no circumcision. And although that kind of study would have been possible back in history, today it's unlikely a trial of this sort will ever take place because of the ethical questions and because few parents would want their newborns to participate. So any research we do have on proposed benefits of circumcision involves healthy newborns or children who were circumcised and looking at them in an observational manner without randomly assigning them to an intervention or control group. Because observational studies are not randomized, we cannot rule out that other factors may be at least partially responsible for any observed effects of circumcision. Now, in our article at evidencebased.com/circumcision, I highly encourage you to check out Table 1, which is the summary of research on the main proposed benefits of newborn male circumcision. What we did in that table is we list the proposed benefit. We state whether there were randomized trials on that topic. We state if there's any alternatives, if there's any non-invasive methods of prevention or treatment for that same proposed benefit. We also list the absolute risk of this health problem occurring, the grade ranking of evidence, and the grade strength of recommendation for the particular benefit that's been proposed. As you will see in the table with each of the proposed health benefits, there's never been any randomized trials on healthy newborns. There are non-invasive methods of prevention or treatment available that can be used as an alternative to circumcision. And the absolute risk of the health problems that researchers are saying we should use circumcision for, the absolute risk of those health problems occurring are low to very low. Also, the grade ranking of evidence is low quality for preventing UTIs, low quality for preventing penile cancer. There's moderate to high quality that you can use topical steroids instead of circumcision to treat a problem called phimosis. There's high quality evidence that circumcision on adult men prevents HIV. However, there's no evidence that that research can be applied to newborns. Also, there's no evidence that those studies can be applied to other areas of the world, including the US and Canada. There is moderate quality evidence that there is a modest decrease in the risk of HPV infection with circumcision, but the strength of the recommendation for this practice is weak. And it's likely that HPV vaccination and safe sex practices are more effective than circumcision at preventing HPV infection. Also, the studies on HPV transmission and circumcision again have to do with adult male circumcision, not newborn circumcision. The grade quality of the evidence for adult circumcision leading to a decreased risk of getting herpes is moderate quality, but the grade strength of the recommendation for practice is weak. And there is really no evidence to show that male newborn circumcision can prevent those males from getting herpes later in life. So you can look in the details of these studies and the non-invasive alternatives, as well as the absolute risk of the problem occurring, the grade ranking, and the grade strength of recommendation for each of those proposed benefits in Table 1 in our paper. Now, in the interest of time, I can't go into depth or great detail about the research on each of the proposed benefits. I've already kind of summarized Table 1 for you. But I did want to talk about UTIs because that's one of the more commonly cited proposed benefits of newborn circumcision. As I mentioned earlier, the grade system found that the evidence for using circumcision to prevent urinary tract infections is low quality, and any strength of recommending circumcising for routine practice is weak. Urinary tract infections, or UTIs, occur in about 8% of girls and 2% of intact boys before the age of 7. UTIs occur more frequently among girls because their urethra, or the tube that carries urine out of the body, is shorter. This infection is treatable with oral antibiotics and usually resolves without complications. However, in rare instances, UTIs can lead to severe infection or kidney problems. Medical providers in the United States often advise parents and guardians that circumcision helps prevent UTIs in male children. And the theory is that bacteria are less likely to grow on the keratinized, dry, tougher skin of a circumcised glans penis. The authors of the most recent Cochrane review on this topic were not able to identify any randomized trials on the use of routine newborn male circumcision to prevent UTIs. We also did a search and we could not find any randomized trials. So the only research we have on this topic comes from observational studies. In a 2008 meta-analysis and review, Shaikh et al. Combined results from 14 studies involving children with fevers who were less than 2 years of age, including data on their rates of UTI. Overall, 7% of children with fevers had a UTI. Out of all the children presenting with a fever, the rate of UTI was highest among intact males under the age of 3 months, 20%, followed by females aged 6 to 12 months, 8%. In contrast, circumcised boys under 3 months of age had one of the lowest rates of UTI, 2%. Now remember, these are all children who were coming or presenting with a fever. In this same review, one study looked at UTI and circumcision status in males with a fever who were 6 to 12 months of age and found that the rate of UTI in intact boys with a fever versus circumcised boys with a fever was 7.3% and 0.3% respectively. The rate of UTI among all males in the review decreased with age starting at around 6 to 12 months regardless of circumcision status. An earlier systematic review by another group of researchers in 2005, led by Singh Grual, included 12 studies with data on more than 400,000 males, many of whom were less than 1 year of age. They found that UTIs were uncommon among males regardless of their circumcision status. 1.38% of intact males got a UTI versus 0.14% of circumcised males. The authors talk about how increased UTIs among intact males might be due to more bacteria around the prepuce. However, they also mention that increased colonization may have led to more false positive results among intact males, potentially overestimating their rate of UTI. They estimated that about 111 circumcisions would need to be done in order to prevent one episode of treatable UTI, which the authors concluded does not justify routine circumcision for all male infants. So those are some details about the proposed benefit of decreasing UTIs. Make sure you go to the article to check out the other in-depth sections about the proposed benefits of decreasing phimosis and inflammation, the HIV virus, HPV virus, herpes virus, other sexually transmitted infections, and penile cancer. Now that's the information from research evidence on proposed benefits. But what are the potential health risks from circumcision? Like any surgical procedure, there's a risk of complications. Unfortunately, the true rate of complications after newborn circumcision is not known. And a big reason for this is because researchers usually only track potential benefits from circumcision and not potential harms. For example, bleeding complications is probably one of the most common risks from a circumcision, but there's almost no research on this topic. When observational studies on circumcision complications are carried out, most of the data usually comes from large retrospective hospital-based studies that are simply looking at medical records to estimate how often bad outcomes occur. These studies are going to greatly underestimate the true rate of complications because they only capture bad outcomes that were charted in the medical record before hospital discharge. We were only able to find 2 studies on newborn circumcision that followed infants for a whole year. Almost all of them are only looking at the first few days of life. In 2010, there was a systematic review on poor outcomes after circumcision published by Weiss et al. They found that complication rates range from 0 to 16%, with most rates hovering around 2%. And the most common early complications were pain, bleeding, swelling, and cosmetic concerns about the amount of skin that was removed. The rate of serious adverse events was 0 to 2%, with most rates closer to 0%. Examples of some rare serious adverse events include having a severe infection requiring antibiotics, one baby who developed a severe ulcer on the opening of the urethra, experiencing a cut to the urethra, having the glans penis accidentally amputated, and those are the serious adverse events in those studies. Now, reoperation is one of the more common risks from circumcision. So after the procedure, parents might think that not enough skin was removed, and there may need to be a second procedure to fix the baby's penis. Studies have reported that rates of reoperation range from as low as 0.1% to as high as 4.5%. Another reason for reoperation might be because there's problems with how the tissue grows back together. During healing, the skin can form scar tissue or adhesions on the glans penis, and this can happen with up to 25% of newborn circumcisions. The risk of having these adhesions can be reduced with gentle retraction and barrier ointments, lubrication until the wound has healed. Another potential problem is phimosis following circumcision, in which the scar tissue covers the glans penis. We also have in the article recent case reports. We searched PubMed for case reports on complications from non-religious male newborn circumcision within the last 5 years, and we found 6 results that we list out in the article. Also, we haven't talked about pain yet, but the surgical removal of the nerve Latin male prepuce is painful and requires pain treatment. Researchers have described that when there is inadequate pain treatment during circumcision, newborns can experience the following symptoms and problems: increased stress chemicals in the body, increased heart rate and breathing rate, decreased oxygen levels, skin turning red or blue, vomiting, increased crying, gagging or choking, and withdrawing or becoming quiet and less responsive to parents. Interestingly, the idea that babies can experience pain like children and adults is a relatively new idea, and it wasn't until the late 1980s that doctors started routinely giving pain treatment during procedures, such as during newborn circumcision. Therefore, if you know a man who was circumcised in the U.S. before the mid-1980s, he probably did not receive any pain medication at all during the newborn surgical procedure. However, today, practice guidelines recommend that all infants have pain medication during and after surgical procedures. The American Academy of Pediatrics says that exposure to repeated painful events in early life can cause short and long-term harms. In the article, we go into detail about the different pain treatments available. The strongest pain treatment and the most effective is called the dorsal penile nerve block, which involves injecting anesthetic around the base of the penis. However, none of the pain treatment options will completely prevent a noticeable pain response to the circumcision. Also, pain may continue afterwards as the wound heals. In the article, we talk about a few more complications. One of them that's not usually measured in those earlier large studies where they look at rates of complications is something called meatal stenosis. This is when the opening of the urethra becomes abnormally narrow. Circumcision is considered the most important cause of meatal stenosis because this condition rarely, if ever, occurs among intact males. About 7 to 20% of circumcised males develop meatal stenosis. It's one of the more common underreported complications because many cases with no or only mild symptoms may be undiagnosed for a long time. Doctors typically diagnose meatal stenosis in children when they're starting to potty train and the parents say that the boy seems to have trouble directing their urine stream into the toilet. Other signs are when boys take a long time to empty their bladder with the small stream of urine, or if the opening to the urethra appears scarred and has a small diameter. Finally, the National Health Services in the United Kingdom informs parents that the main risk of circumcision is a reduced sensation or permanent change in the sensitivity of their child's penis. They go on to say that circumcision shouldn't affect your ability to have a fulfilling sex life in the future, but loss of sensation is one reason why in the United Kingdom they only recommend circumcision if you have a medical need for it. Now, the role of the male prepuce in sexual function is a subject of a lot of debate. Everybody agrees that the prepuce has a lot of sensory nerves that are completely removed during circumcision. However, the main question is whether or not this loss of sensation leads to a decrease in a man's sexual pleasure later in life. There was a recent meta-analysis on this topic published by Yang in 2018, and they looked at premature ejaculation or difficulty of orgasm. Overall, they found that circumcision has no statistically significant impact on either of those two factors. We also found 2 recent studies that measured sensation of the penis in sexually healthy men who were circumcised as newborns or left intact. In one study by Sorrells that was published in 2007, they looked at the fine touch sensitivity of 19 locations on the penis. They included 91 circumcised men and 68 intact men. The region most sensitive to fine touch was the prepuce of intact men and the circumcision scar on the underside of the penis of circumcised men. And they concluded that the most sensitive regions of the penis are those removed by circumcision. 5 locations on the intact penis were more sensitive to fine touch pressure than the most sensitive location of a circumcised man. Another study published in 2016 by Basio also found that the male prepuce is the part of the penis most sensitive to fine touch pressure. So researchers agree that the male prepuce is the most sensitive part of the penis to fine touch pressure, but they disagree about how relevant this is for having a sexually fulfilling life. There's also a really interesting study published by Basio and Pukal in 2018, and they studied 811 men from around the world. They gave them an online survey about their attitudes toward their circumcision status, their body image, and sexual functioning. So in the study included men who were circumcised as newborns, men who were circumcised in childhood, some who were circumcised in adulthood, and some of them who were intact. Interestingly, they found that men who were circumcised as adults and the intact men reported the highest satisfaction with their status, compared with those who were circumcised in infancy or childhood. The authors speculate that choice plays an important role in how men feel about their circumcision status. And men's attitudes were highly variable within the sample, suggests that men develop wide-ranging feelings about their circumcision status, which can't be predicted in infancy. Whew, if you've stuck with me through this part, we're getting closer to the end. Now I want to talk about this evidence in the light of ethics and human rights. So what Anna Bertoni and I did is we did another literature review searching for articles written in English about circumcision and ethics that were published within the last 10 years. We narrowed the results down to the 21 articles that discussed routine, non-religious male newborn circumcision. Of these 21 papers, 13 made the case that circumcision is unethical. 5 papers argued that it's ethically justified, and 3 papers simply discussed both viewpoints. So first, let's cover the view in the literature that routine newborn male circumcision is not ethical. The papers on ethics that we found opposing routine male infant circumcision came from authors in the U.S. There are 5 papers from the U.S., 3 from Germany, 3 from Australia, 1 from Italy, and 1 from Israel. What we found from reading the literature is that the majority view in recent bioethics research is that routine newborn male circumcision is not ethical, and they state the following reasons. They state that children have a basic right to bodily integrity. It's an irreversible surgery on healthy minors who cannot give consent. It causes unnecessary pain and trauma during the surgery and suffering as the wound heals. There are immediate post-surgical risks as well as unknown risks, which together may outweigh the benefits. It deprives the male of tissue that normally protects the glands and the urinary opening. It prohibits any future sexual functions and sensations that involve the prepuce and prevents any sensations that would be transmitted by the now missing nerve endings. There are less invasive and more effective preventions and treatments available for many conditions and addresses. For example, you could use condoms to prevent HIV and antibiotics to treat a UTI. They also state that there's a double standard, a rule that is unfairly applied to one group but not another, since society would consider it unethical to routinely remove healthy tissue from a female infant's genitals, even if there was evidence of potential health benefits. On this last point about the double standard, we found frequent comparisons of male circumcision and female genital cutting in the ethics literature. And I feel it would be impossible to share the main ethical argument around bodily integrity without discussing this comparison and explaining the comparison that the authors make. Some researchers actually use the term, quote, male genital mutilation instead of saying male circumcision. But others find this comparison and choice of words extremely offensive. The language or terms that people use to discuss genital surgery often reveals their beliefs about the ethics of the practice. For example, people who support female genital cutting usually prefer the term female circumcision, since mutilation implies that the practice is wrong. According to the World Health Organization, female genital cutting is an ancient practice that is still common in parts of Africa and in some countries in the Middle East and Asia, as well as among migrants from these areas. Prevalence rates, for example, are over 80% in 8 African countries. Female genital cutting is usually performed by older women in the community on young females between infancy and 15 years of age. The World Health Organization says that the reasons for the practice vary, but the most commonly cited reasons are because it's socially normal, beliefs that it will protect virginity before marriage, a desire to reduce women's sexual drive, and cultural ideals of femininity, hygiene, and beauty. Some Islamic communities that practice female genital cutting believe that it is part of their faith. For example, in Malaysia, one interview study carried out by Rashid and Iguchi in 2019 found that 99% of participants had experienced female genital cutting themselves, and 88% believed that it was compulsory in Islam. According to the people interviewed in that study, they believed that the girl's genitals must be scratched to draw out a single drop of blood in order to fulfill the ritual. However, female genital cutting or female circumcision is not mentioned in the Quran, and many Islamic scholars refute the idea that it is an Islamic religious practice. The World Health Organization classifies female genital cutting into 4 major types, and the numbers do not classify by order of severity. Type 3 is the most severe type of female genital cutting. It's often referred to as infibulation. It involves narrowing the vaginal opening with stitches, with or without removal of the external part of the clitoris. Infibulation accounts for about 10% of all cases of female genital cutting. It has devastating health consequences, can cause many severe health problems, including sexual pain, increased risk of having complications or even dying during childbirth, menstrual problems, and urinary problems. The other types of female genital cutting range in severity. Type 4 includes any injury to the female genitalia for non-medical purposes, so that includes pricking, piercing, or scratching tissue to get a single drop of blood. In some cases, particularly type 1A, female genital cutting involves removal of the female prepuce or the clitoral hood. This is also called a hoodectomy or clitoral unhooding. Every type of female genital cutting is recognized internationally as a violation of the human rights of girls and women, even when it does not remove any tissue, for example with the prick, and even when it is medicalized or performed by healthcare providers in a clinical setting with anesthetics. There are no known health benefits from female genital cutting and significant harms. And researchers are not looking for any evidence of health benefits, for example, a reduced risk of infection from removing the labia, because it would not be considered ethical to do so. Of the ethics papers that portrayed male circumcision as unethical, 12 out of 13 groups of authors compared male circumcision to female genital cutting in such a way as to suggest that both practices are unethical. Even though some types of female genital cutting are much more severe than male circumcision, the authors shared a view that all people have a common right to physical integrity, regardless of sex or gender, and regardless of the degree of cutting. One author, Darby, who published a paper in 2016, called it, quote, a moral hypocrisy or intellectual inconsistency, end quote, that there is total protection for females against genital cutting, but no such protection for males. And they also claimed that people in the United States show a cultural bias favoring Western cultural practices over those of, quote, other cultures. And today, there are large international efforts with significant U.S. involvement, such as the Brussels Collaboration on Bodily Integrity, that, quote, aim to protect all non-consenting persons, regardless of sex or gender, from medically unnecessary genital cutting. So that's the view that routine newborn male circumcision is unethical. What about the view that routine newborn male circumcision is ethical? Well, the papers on ethics that we found supporting routine male infant circumcision as an ethically sound practice came from 3 authors in the United States, 1 from Saudi Arabia, and 1 from Canada. Some of the reasons they gave for supporting the practice as ethical include they stated that male newborn circumcision confers a wide range of medical and public health benefits over a lifetime. Its known benefits outweigh its known harms. The procedure is minor and the risk of complications is low. You can use injectable local anesthetics to reduce pain. Autonomy is respected by allowing the parents to decide in the best interests of their child. Families have the right to practice their religious and cultural beliefs. And we live in a diverse society that must be tolerant of families who elect the procedure for cosmetic preference or family tradition. They also had the view that delaying the option until the age of consent in adulthood misses some of the benefits of circumcision in early life, such as the proposed reduction in UTIs, and results in a higher rate of complications than when done in infancy. Some researchers who advocate for routine newborn circumcision point to infancy as the optimal time to circumcise and claim that there are fewer complications with infants, that the procedure is less expensive and it can be done more quickly. In 2010, a researcher by the name of Weiss combined prospective studies and found that circumcisions done with children age 1 or older are associated with more complications compared to newborn circumcisions. The complication rate was 6% with children versus 2% with infants. However, many of the older children in the studies were circumcised for medical reasons, unlike the newborns, and complications are more common after medically indicated circumcisions. The 3 African randomized trials looking at adult circumcision and rates of HIV found a complication rate ranging from 2% to 4%. Critics of newborn circumcision argue that the absolute risk of complications is not very different between adults and newborns, and said it's more ethical to wait until a man can decide for himself if he wants the procedure. As I mentioned a little bit earlier, of these 5 papers on ethics that we found supporting routine male circumcision for infants, they talked a lot about the significant medical and public health benefits from circumcision and that the known benefits outweigh the known harms. And so I would refer you to the extensive sections in the evidence-based birth article on circumcision for more information about whether or not the evidence supports or does not support these claims. So going back to the beginning, remember I talked about those bioethics principles? Well, at the end of our article, we kind of summarize how newborn male circumcision relates to the bioethics principles. Autonomy in this case can be thought of referring to the autonomy of the child or the autonomy of the parents. If you're considering the autonomy of the child, non-therapeutic circumcision violates the principle of autonomy because infants are not being allowed to make informed decisions about their bodies when they get older, because you're removing the opportunity for them to make that decision themselves. Now, if you're focusing on the autonomy of the parents, proxy consent is a way for them to exercise their autonomy. However, some of the ethicists whose work we read argue that proxy consent is not valid for an elective surgical procedure, since it's not actual treatment for an existing medical problem. Now, the principle of non-maleficence, or do no harm, says that a provider must not intentionally inflict harm on a patient. Some ethicists argue that circumcision violates this principle because it's an unnecessary surgery that causes injury to an otherwise healthy child and introduces the risk of surgical complications. Others disagree and believe that circumcision results in a net benefit for the patient because of a reduced risk of some health problems. However, the health problems that circumcision may protect against can be prevented or treated through non-invasive means. Furthermore, many parents are choosing circumcision for social reasons, and in these cases, the surgical procedure is done to the child more for cosmetic reasons rather than out of health concerns. When children have actual medical problems that require surgical intervention, parents usually have the authority to decide what's necessary. However, it's a different ethical situation when a child is healthy and not experiencing any medical problems. The third principle of bioethics was beneficence, which means do good. Now, when you're applying this to elective circumcision, this means that the benefits from the procedure should clearly outweigh the harms. Some researchers and medical groups in the United States believe they do, but the majority of medical groups around the world that have issued practice guidelines on this topic have not found that the benefits outweigh the harms. This is especially true considering that the harms are still largely unknown, and it's difficult to assign a value to keeping a healthy sexual organ intact. Finally, the bioethics principle of justice holds that individuals should not experience discrimination in healthcare on the basis of sex, race, or religion. Interestingly, the dominant view in U.S. culture holds that routine male and intersex genital surgery is normal, appropriate, and even beneficial during infancy, but procedures to alter the female genitals, no matter how minor and regardless of the reason, is foreign and a horrendous violation of a young girl's right to bodily integrity. Brian Earp, an associate director of the Yale Hastings Programs in Ethics and Health Policy at Yale University, explains his view that male circumcision of minors is so familiar in U.S. culture that it was, quote, grandfathered in, end quote, to be perceived as an ethically sound practice. But new proposals to prevent future medical problems by removing healthy tissue from healthy infants would never get ethical approval today. Also in the article, we talk about practice guidelines around the world on male circumcision. Among the rest of the world, the U.S. really stands alone in terms of professional preference for non-religious circumcision. For example, in 2012, the American Academy of Pediatrics, or AAP, issued a position statement on newborn circumcision. The statement is now expired and no longer in place. They have chosen not to renew it or to post a new one. But their former statement said that, quote, the health benefits of newborn male circumcision outweigh the risks. Furthermore, the benefits of newborn male circumcision justify access to this procedure for families who choose it. However, physicians from more than a dozen countries with 38 co-authors published a rebuttal to the AAP statement in the Pediatrics Journal. They argue that cultural bias can cause people from a circumcising nation to interpret the same evidence differently from non-circumcising nations. In fact, professional statements in the U.S. appear to be highly influenced by U.S. culture. The American Academy of Family Physicians policy from 2018 states that the potential health benefits justify circumcision being covered by third-party payers. The CDC's 2018 recommendations state that healthcare providers should counsel male patients and parents about the risks and benefits of circumcision. And they cited the AAP conclusion that the benefits of newborn circumcision outweigh the risks. The American Urological Association published a policy statement in 2017 stating that there are both benefits and risks and that circumcision should be based on parental preference. In the American College of Nurse Midwives 2017 position statement, they recognize that midwives may provide newborn male circumcision as part of an expanded scope of practice. They state that the procedure should not be routinely recommended, but they believe it should be considered on an individual basis according to the parent's preferences. The American College of Obstetricians and Gynecologists published a patient education brochure on circumcision in 2017. They describe male newborn circumcision as an elective surgical procedure and state that it is the parent's choice whether or not to have their son's penis circumcised. It's also interesting to read U.S. professional statements on male circumcision and female genital cutting side by side to see how American organizations recognize these as two distinctly different practices with different ethics. ACOG, AAFP, and ACNM all have position statements on female genital cutting. For example, ACNM affirms that midwives should not perform any type of genital cutting or pricking on females. It's their position that this would be a, quote, gender-based human rights violation that threatens the basic rights of girls and women, including their rights to health, life, physical and sexual integrity, human dignity, self-determination, and freedom from torture, violence, and bodily harm, end quote. Outside of the U.S., professional organizations have issued statements on circumcision even when circumcisions are rarely performed for non-religious reasons in their countries. The National Health Service in the United Kingdom says that it's rare for circumcision to be recommended for medical reasons in boys, and they cite the main risk of circumcision to be a reduced sensation or permanent change in the sensitivity of a child's penis. The Canadian Pediatric Society does not recommend routine newborn circumcision. They state that if a procedure is not medically necessary, the intervention should be deferred until the individual concerned is able to make their own choices. The Canadian Urological Association evaluated the evidence on circumcision in their 2017 position statement, and overall they concluded that routine newborn circumcision is not justified. The Royal Australasian College of Physicians says that routine infant circumcision is not recommended in Australia and New Zealand. The British Medical Association says that there's a wide spectrum of views within their membership. They state that any informed consent discussions should include the fact that there's a lack of consensus among the profession over the benefits. Interestingly, they say that parental preference alone does not constitute sufficient grounds for performing newborn male circumcision. In addition, they state that doctors should only perform circumcisions on children if they can document in the medical record their reasons for believing it to be in the child's best interest. And they also state that doctors can refuse to perform a circumcision if they do not believe it is the overall best interest of the child. Kind of as a side note on the subject of refusing to perform circumcision, doctorsopposingcircumcision.org is a website that provides free legal advice to any medical professional struggling with whether or how to assert conscientious objection for circumcision. So as you can see from the sampling of position statements that I've just brought to you, the rest of the international community stands apart from the more favorable position on circumcision seen in the U.S. In general, outside the United States, it's thought that although you might want to honor parents' preferences, the procedure does not offer obvious benefits over risks, and it should not be encouraged. To be clear, professional associations in the U.S. also do not consider circumcision to be medically necessary. However, these organizations are unique in promoting the practice as having more benefits than risks. And physicians in the U.S. are unique in that they routinely offer circumcision to the parents of every male infant born in a hospital setting. I did want to note that, the AAP position statement that's expired, but that so many people cite, that the task force that created that statement did not follow any objective scientific criteria for assessing or evaluating risks and benefits. In a commentary that was published later in the journal Pediatrics, one of the members of that task force, Andrew Friedman, explained that it appears that the AAP task force was at least partially motivated by a desire to keep circumcision available as a parental choice when it published its 2012 statement about, quote, benefits and risks. So depending on where you live, care providers may discourage, encourage, or take a more neutral stance on newborn male circumcision. And even within countries or within provinces or states, individual doctors vary in whether they promote or discourage the procedure. As far as I know, no country has yet made the practice illegal, although its legality has been disputed in several countries. At the other extreme, no country has yet recommended universal circumcision, or circumcising all newborns for public health reasons. But whenever this issue comes up, in terms of banning circumcision, it ignites a fierce controversy over human rights and parental religious freedom. So now we've made it to the summary. I want to end by saying that in the US and around the world, routine newborn circumcision is considered non-therapeutic or not medically necessary because it does not treat or cure any existing disease. By now, you should not be surprised to know that parents' decisions about non-religious circumcision are highly influenced by social and cultural factors, and less so by beliefs in medical benefits. If they do cite the medical benefits, often it's from the American Academy of Pediatrics viewpoint that, quote, the benefits outweigh the risks. Without a true understanding of the deep limitations of the research on this subject and the fact that most of the research on this topic about purported health benefits comes from circumcising adult men. After an extensive review of the literature, it seems that there's no compelling evidence to justify routinely circumcising male infants on medical grounds. Most of the evidence on risks and benefits is still highly disputed in the research. There have never been any randomized trials on routine male newborn circumcision to support the litany of proposed benefits. The evidence from randomized trials on benefits for HIV, HPV, and HSV or herpes comes only from adult male circumcision in African countries. This evidence cannot be applied to newborn male circumcisions, nor can it be generalized to lower risk populations when you have a country with much lower rates of female to male HIV transmission, lower rates of herpes, and access to the HPV vaccine. Also, the evidence on the extent of the harms of circumcision is limited, but we do know that there are potential harms, and some ethicists point out that the procedure itself is the harm because it violates the child's bodily integrity without any urgent medical indication. However, the routine situation in the United States is that parents are almost always offered a routine circumcision in the hospital, and they're not usually given complete information on the ethical debate, risks, limitations of the research on proposed benefits, or alternatives. If information is offered, it frequently presents the AAP view that, quote, the health benefits outweigh the risks, without a global context to show that this view is unique to U.S. culture. Most parents have no understanding about the historical reason for the cultural preference for non-religious circumcision, that it was popularized to prevent masturbation, sexual deviance, and promiscuity. Most parents are not aware of the mounting ethical debate around circumcision, and most parents are not informed about non-invasive alternatives for preventing or treating health problems such as urinary tract infections. Our hope is that by publishing this article, that it will help parents and healthcare professionals to critically think about the practice of routine circumcision, especially in the U.S., where the majority of non-religious circumcisions are being carried out due to social pressure to conform, not necessarily for true medical benefit. I hope you found this podcast helpful. I know this is a heavy topic, a controversial topic, an emotionally charged topic. It's our sincere hope that the information in this article leads to mutually respectful conversations between those with diverse perspectives on circumcision. And at the end of the article, we have some questions for discussion for parents and professionals, including what surprised you most? What did you think about the history of circumcision? What emotions did you feel while reading this article or listening to this podcast? What are your thoughts on the ethics of routine newborn male circumcision? Do you think parents choosing circumcision are typically presented with all of the information that we covered in this article? Why or why not? Because this article and this topic is so controversial, my co-author and I wrote a disclosure statement, which you can find at the end of the article, and I'll summarize it for you here. Basically, it says that we endeavored to leave our personal opinions out of this article and podcast on circumcision, and instead we chose to highlight the wide-ranging voices of experts in the medical and bioethics literature. We do acknowledge that it is possible that personal biases may have influenced our review of the literature to some extent. As a safeguard against bias in evaluating the research, when we talked about the grade recommendations in this podcast, these came from the Canadian Urological Association. When reviewing the ethics literature, although my co-author and I were skeptical about non-therapeutic surgical procedures on children, we entered the bioethics literature search with an attitude of curiosity and a desire to learn. The article on which this podcast was based was sent for peer review to a variety of experts in the field, including researchers, clinicians who perform circumcisions, and clinicians who do not perform circumcisions. My co-author and I have no professional partnerships with pro-circumcision or anti-circumcision activist organizations. Next, I want to talk a little bit about some of the additional resources where you can take your learning to the next level. If you'd like to learn more, I highly recommend the book Circumcision, A History of the World's Most Controversial Surgery by David Gallagher. And we have a document or webpage with our answers to frequently asked questions at evidence-based-birth.com/circumcisionfaq. We will be coming out with a one-page handout, and people who are in our professional membership program or taking our childbirth class will have access to a full-length printer-friendly PDF of this article inside their PDF library. If you're going to be talking about this topic with other people, I also highly recommend that you listen to the podcast episode 87. That's Evidence-Based Birth Podcast episode 87 with Kristen Pascucci, where we talk about how to discuss controversial topics respectfully and how to disagree respectfully. Thanks so much for sticking with me through this long episode. I'll see you next week. Bye.